So hello, everybody. Welcome to today's session. As people are joining in, if you'd just like to introduce yourself in the chat, so open up the chat and let us know who you are and what OHT you're from or other organization, if that's the case. And then just a note, if you can make sure to respond to everyone in the chat box, not just hosts and panelists. So we have Mandy Lau from East York Region North Durham OHT, Veronica Nelson from Kawartha Lakes OHT, welcome. Judy Hill from Ottawa Valley OHT, lots of others joining. Jeff Dorans, welcome everybody. David Townsend, Teresa Greer from Mississauga OHT. Oh. Great, so keep it going and introduce yourself, let us know who you are. It's nice to get a sense of who you are, even if we can't see you today. So to start us off, on the next slide, we just want to start by acknowledging this land in which the University of Toronto operates. So for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Thanks. And we see lots of more introductions in the chat. So again, welcome everybody as you're joining on. We'll start with this poll. And Nusrat, if you can launch the poll. We just like to know, those of you, if this is your first HSPN webinar or if you've joined us already. And over time, we expect to see less and less people with their first webinar, but there's always new people. And we can see that 70% have joined us before, but still 30% or about 60 people, this is their first event. So welcome to those who've joined us before and to those who are new. Thanks for joining. So we stop share. And then, so today's event, we're going to be focused on patient experience in OHTs. I'm taking over the role of host for today. And we have an all-star lineup, including, we'll hear from Dr. Walter Wodchis, who is a co-lead for the OHT Central Evaluation. He is the principal investigator for health system performance and a professor at the University of the Institute of Health Policy Management and Evaluation. Many of you would know him. We have Dr. Carrie Koleski, who is a research chair in patient-centered care at the Institute of Better Health at Trillium Health Partners and faculty at IHPME, and she is a co-investigator with HSPN. We'll hear from Sarah Grace Babnick, who is a project manager from South Georgian Bay Ontario Health Team. And she brings years of experience in knowledge and quality improvement, project management, patient advocacy, and health policy to her role in co-designing high-performing integrated health systems. We'll also hear from Sheila Koss, who is a retired dental hygienist with a background in active military service, private practice, and most recently teaching at Georgian Bay College in Barrie. As a healthcare provider, Sheila believes that integrated client-centered care is vital to the healthy communities, and she has a desire to help her community by volunteering with the South Georgian Bay OHT PFAC. And finally, we'll hear from Zahra Ismail, who is the Senior Director of Primary Care and Social Determinants at Ontario Health. And she provides strategic oversight and direction for program areas, including primary care, patient-reported measurement, and patient-provider experience. So welcome to all our panelists that we'll hear from. So before we get started on today's topic, I just want to introduce the Quadruple Aim. Many of you who would be familiar with this, but it is an internationally recognized framework for healthcare integration. It is one that the delivery model of OHTs is expected to achieve results in this area. So we have patient experience, which is our focus of today. We have population and patient health outcomes. We have improved value or reducing costs for healthcare, and finally, provider experience, work-life experience. So over the next few webinars, we'll actually be focusing on a different aim within the quadruple aim. And I would also like to highlight the importance of equity. So while it isn't a particular aim in this framework, it can and should be integrated into measures in each of these 4 areas. So with that, our focus for today, we'll start by hearing about patient experience measurements. So we'll hear from Carrie about attributes of person-centered care, and then from Walter about the HSPN patient survey. Then we'll hear from on-the-ground experience of measuring patient experience in South Georgian Bay, Ontario health teams, and finally hear from Ontario Health in terms of past experiences and future directions in measuring patient experience. And then just to highlight, we will have a few more polls and discussions throughout, but we do like to hear from you and ongoing. Please type into the chat in terms of what types of discussion have you had or are you having in your OHT that pertains to measuring patient experience. So we'd really like to hear from you and get an understanding of what the different OHTs are doing. So I encourage everybody to share in the chat. So first up, we'll hear from Carrie.
Great, thank you so much, Kaylee, and great to be here this afternoon. So hello, everyone. And I'm really excited to talk about some work that I was involved in, which really tried to unpack what is patient-centered care, what is person-centered care. So we often hear these terms that are thrown around and they're used, but we don't always unpack what they actually mean. And so in this project, this was part of a large multi-jurisdiction community-based primary healthcare study, which was led by Walter Wodchis. And I had the honor of leading the piece related to the patient and family experience. And we really wanted to understand person-centered care by asking the question that you see at the top of your screen. And that is, what is important to patients and caregivers? What do they value? What matters to them? And when we asked these questions in the study, we didn't want to know just about their health conditions and their healthcare needs. We wanted to know about what mattered to them in general in their life and living a meaningful life. So we conducted 172 one-to-one in-depth interviews with older adults that had multiple chronic and social care needs. We also interviewed caregivers of those types of patients, and they were based in Canada, so specifically Ontario, Quebec, and many jurisdictions in New Zealand as well. And so what was great about these interviews is that the majority of the participants were from communities that were underrepresented, ethnically diverse communities, Maori populations within New Zealand, Southeast Asian, Indigenous, so lots of different types of patients and families were involved in these studies, and not just middle class, Caucasian, English speaking. So we did a lot of interviews that were translated as well. So it was quite an inclusive sample. And when we interviewed them, we unpacked core attributes of person-centered care. So you can see on the figure or the picture that you see on your right-hand side is a summary of those attributes. So ultimately, and this will not be surprising, people want easy access to health and social care. So healthcare being primary health care, home care, activities of daily living, but also social care. So socialization, access to healthy meals, transportation, and ideally, if all of those things are under one roof, are in close proximity. So community care hubs or primary care health centers that are, embedded with people's communities where they can be with their community. So people wanted easy access to health and social care. That was enabled by those 3 circles that you see in the middle. So ultimately, both patients and caregivers wanted to have at least one person on the team who they could count on. So someone who could be easily contacted, who would respond quickly. It could be a primary healthcare provider, a nurse practitioner, a volunteer, someone who worked in the community. So someone who would respond quickly, but most importantly, have access to a broader team to get resources, to answer questions, to support the patient and the family. And once the person or the family was connected to the care team, they really wanted to feel heard and feel comfortable. So they wanted to interact with their team and have the team ask them questions about their life, about the things that they valued, about the activities that they wanted to keep doing in their day-to-day life, not just about their health conditions. And they also wanted to know how to manage their health presently, but also what to expect down the road, particularly in cases where the person might have dementia, they might be declining, and the family member really wanted to understand, what do I need to prepare myself for to live a meaningful life, and for mom or dad to live a meaningful life down the road. And then you can see on the outside of the circle, two other attributes that were important to both patients and caregivers were being independent, so living a meaningful life, doing activities to the best of their ability, having choice in their care plan, but also feeling safe. And so being able to live independently, have the assistive devices that were needed, feeling connected, having support if they had to go see a family doctor, so transportation. And those things tended to trade off a bit. So if we look at if anything was different between patients and caregivers, the feeling safe thing was really, really critical for the caregivers. They focused a bit more on that. And sometimes they worried that it would get in the way of the independence of the person they were looking after, because they were concerned about the safety of that individual. Whereas for the patient, they were more concerned about having a long, independent life and living, in their own home, if that was an opportunity, for as long as possible. So in the practice guide that you see on your left-hand side, we unpack each of those attributes that you see in the picture. So we unpack, what does it mean to be heard? What's happening in that interaction? What does it mean to have someone to count on? What does it mean to know how to manage your health, etc.? And so you can see kind of all the little details about what patients and family told us about what those attributes mean when they're actually activated. And as Walter will talk about coming up, he'll talk about how this foundational work then helped to shape the data collection tools that were created afterwards. And you can access this practice guide at the link that's provided here at the bottom of the screen. And we also have a manuscript which outlines some of the interview findings and quotes that relate to each of the attributes. So I'll leave it there. Thanks.
Great, thanks, Carrie. Thanks for sharing. Just a little bit of time for discussion here. I'm wondering if anybody has any questions about the attributes. And if you have any thoughts that if you think there should be other attributes included. Not much comments in the chat right now, so crystal clear, Carrie. Yeah, good job on explaining the key pieces that are important. Someone commented that they'd like to see medical and social care included. Accessibility for people with language barriers, like aphasia. And then somebody else asking for the link to be placed in the chat, so we'll get that to you for sure. There's a question here, what are the major differences between geographical locations? Did you have a comment on that?
Yeah, I think, we saw that the models of, we didn't look, I'm trying to think if New Zealand had more of a rural location, because the ones that we included in Quebec and Ontario didn't really capture kind of like the rural remote areas, though I believe some of the New Zealand cases did. I'd say the big difference between these different jurisdictions is just the models of care were different, and the types of resources that were included as part of their kind of universal health systems differed. So there were, a different array of health and social resources provided for these different models that we looked at, which made a really big difference in terms of how supported and how connected people felt. So in some models, and there's one in New Zealand, they had social workers and nurses that would go to people's homes proactively, people that were aging, maybe they hadn't shown up for a doctor's appointment, would show up proactively just to check in, to build a relationship, to see what might be needed down the road, and could start to support self-management to prevent further decline. And I think Ontario has similar models. We didn't happen to look at that in our study, but it was a really nice way of going to people instead of expecting people to come to you when they're already quite frail. So that was a really kind of distinct model that we looked at in New Zealand. There was a question too about barriers in terms of aphasia. The barrier that came up around language, because we did some of our interviews with an interpreter, The importance about having volunteers to accompany people to appointments was really important. So one of the models of care that we looked at had a very large Asian population, many who didn't speak English. And so their volunteers were critical to attend appointments with patients, to translate, and to make those connections. And was also important for those patients to have a provider that spoke their language. Because a lot of other things in terms of the person-centeredness of that interaction would be in place if that person was from their communities, they could speak their language, understand their customs, and those types of things. So that interpretation piece was key, and also really helped people to fully understand their care, what was required, and how to care for themselves.
Great. So a comment just about the attributes, offering a broad range of patient caregiver defined needs, and that can be tailored. A couple comments in terms of social prescription and other services that would help patients achieve their outcomes. So access to that being important. And a question here, did you look at the NPLC model of care, team approach, client-centered care?
I don't believe so, but I would, if there's a link to that we could look at, that would be great.
And a couple other comments about some potential resources. Do you standardize client feedback, i.e. satisfaction survey? So I think that might be a question when we get to the survey part of it.
Just to hit on the social prescribing comment that you made, access to social care was so critical. And I think we all know well in Ontario that traditional home care services that are government funded tend to focus more on the medical side. And unless you have really significant medical needs, you might not qualify for instrumental activity of daily living support. And depending on the community that you live in, you may or may not have access to day programs, socialization, all those types of things. I think this is the audience that's very well aware of that. But a lot of the people we interviewed talked about how critically important that was, including respite for caregivers to have a break, but with a trusted team. So they felt like they could really, truly get away, not feel guilty, but know that, you know, the person they were caring for was in good hands with someone that they trusted. So yeah, the social piece, IADLs, really, really critical.
Great, and there's a couple more questions here, and we only really have time for one more. So if you want, you can respond to some of them in the chat later, but just one comment from Mulugeta that some evidence also indicates that sometimes healthcare providers engage more with caregivers instead of patients. Do you have any reflections about this, or did you hear anything related?
Yeah, you know, a lot of for the clients that had dementia, we didn't interview them. We mostly interviewed their caregivers. But I think when we think about shared decision making, I think where possible, it's ideal to have the patient involved to the extent that they can be with their family and the care team to get all of those perspectives. Some previous work that we had done on goals of care really showed that, you know, the patient has one perspective, the caregiver has another perspective, which is really critical, but it might be different from the patient. So it's really good to understand both perspectives in addition to the care provider. And then it offers an opportunity to talk about compromises, trade-offs, you know, because I think everyone kind of has to give a little to kind of create the best care plan. So by involving the client as much as possible is really obviously really important to do. And it gets really tricky, but it shouldn't be an exclusionary factor. If someone has a stage of dementia, they should still be involved to the extent possible with their family.
Great, thanks everybody, and thanks for all the comments. Keep them coming, and we can do our best to respond in the chat. Next up, I believe we'll be hearing from Walter.
Great, thank you, Carrie, so much for explaining, because it really is the foundation of the work at HSPN in the space of client and caregiver experience. And I see that there was a question near the end of that chat about caregivers and their engagement and involvement. And we have previously developed some caregiver experience measures, and it is our intention have a caregiver specific measure for OHTs. We've kind of fielded that up early on in the OHT days, and I think it was met with some interest, but not widespread. And so we put it off for a little bit. We have developed complementary caregiver surveys to client surveys previously, and so it's top of mind for us. And I think they're separate audiences, and they really need their own approach. So this really is the foundation for how HSPN is measuring patient experience, and we have fielded a tool to made it available to all OHTs, and that's what I'm going to talk through here is some of that. We're going to start quickly with a bit of a poll, though, to sense from the audience, how have you included patient experience measurement in your plans as an OHT or in the OHTs that you are aware of? And so Nusrat can bring up this poll for everyone to have a see. And then we'll get a sense of whether you've done it from a ministry agreement perspective, whether it's part of your quality improvement or CQIP, or whether it's just part of your internal measurement, or whether you are not there yet in terms of measuring. So we'll leave this up and see, watch to see. Let's just see how things are. And we see now that most people, or the largest category, is about measuring as an internal process for monitoring, and that's fantastic. I do see there's if you put together the ministry OHT agreement and this quick quality improvement plans, it actually adds up to about almost 70% of people have made it formally part of their work, which is excellent. And 20% are not planning to measure experience as of yet, where they aren't measuring experience as of yet. And hopefully that will change in the next hour. Thank you very much. And now I'm going to talk about how we developed this. So as Carrie had said, the extensive qualitative analysis, we have also, previous to working with Ontario Health teams, developed surveys for other programs. So one was in home care, where we developed a tool for client experience in home care and a tool for caregiver experience in home care. And that was on behalf of Health Quality Ontario and under the advisory of a panel of stakeholders in Ontario, led by Gail Donner. Then we've also had surveys in bundled care, in health links, and provided that feedback back to the providers. Most important thing to me is that if the data aren't being used, then we're all wasting our time. That we need to both collect and use the data as many times and as extensively as possible. And as we were moving into the Ontario Health teams, we had to develop this tool before Ontario Health teams had really started to move to implement new models of care. And so we did engage with many patients and caregivers that were involved in the development of the Ontario Health teams from the outset. And we intend to continue to evolve and evaluate the instrument and move it forward. One of the things that we had done with this tool is to also have it embedded within the Ontario Healthcare Experience Survey, which is a representative sample of all Ontarians, so that we could have a sense of what the general population responds to before going into OHTs. So the survey that we have developed has the 6 attributes of patient-centeredness, patient-centered care, including those that Carrie just reviewed. We've added a few others to those. One is around the health services that people are using and their use of digital health. And we've specifically identified transitions as being an area where many OHTs might be seeking to make improvements. So in collaboration with Ontario Health, we added in some questions around transitions from acute emergency departments between physicians and in labs, about information flow and whether people are actually connecting across these providers. We also include a number of sociodemographic and socioeconomic measures, age, gender, and race, as well as income, food, and housing security, and social isolation within this tool. And so let's just take it down to some examples, questions. The tools are available on our website, as well as some videos on how OHTs can use them. But just as an example around easily accessing care, people would report on their experience with access to their usual provider. And how would you describe the length of time it took to access your provider? About right, somewhat too long, or much too long. Some of it would be having someone to count on. In general, how confident are you that the usual provider or other care professional checks up to make sure that you receive the health care that you need? So that follow-up, that being there for you and having someone to count on all of the time. As an example for being heard, we talk about involvement. So one of our questions asks, when you see your usual provider or someone else in their office, how often do they involve you as much as you want in decisions about your care? And then we have people rating from always to never. We go a little deeper. I'm just giving you some example questions here. For example, in this one, we also ask whether people feel that they've been heard and understood in this space as well. So not just being involved, but also being heard and understood. Here's some of the questions about the transitions. When you left the emergency department, how confident were you that you had the information you needed to care for? And around specialists and providers, did your usual healthcare provider seem informed and up to date about care from the specialists? So trying to get at whether we're seeing improvements in the information flow and the shared care for patients with needs that cross multiple providers. The other area that we have included is a patient-reported outcome measure, and later on we're going to hear from Zahra. So mostly we've been talking about patient-reported experience measures so far, but we also have an outcome measure. This gets a little bit towards that space of being independent and your overall health. So it's related to that dimension. And we're using here the Euroqual 5-dimension 5 level, mainly because it is the most practical measure in our context. And it's also being used in many circumstances across Ontario. So it asks questions around mobility, self-care, usual activities, pain, discomfort, and anxiety or depression. We also have a couple questions from the patient healthcare questionnaire, PHQ-2, which asks around specifically mood and safety. That's what I wanted to talk about in terms of the questions, just so you have a sense of what's in that tool, how we brought it to life from Carrie. And the other thing I wanted to just show one of is I mentioned how, well, first off, Kaylee mentioned how we bring equity to everything. And I talked about these other dimensions around sociodemographic and socioeconomics. So this, I'm going to put up a graph that has one of our data results taken from earlier this winter, from early on when we were first fielding a survey around looking at income insecurity and access. So it goes back to that question I put up, how easily were you able to access your usual provider of care? And you can see, about right is the bright green, somewhat too long or much too long. And if we look at how people responded to the question of do they have difficulty paying their bills at the end of the month, we see that there are differences in this access question. And while it's only about 6 or 7% of people have waited much too long when they have no difficulty paying their bills, it's about 17%, so more than twice that. And so there's something going on here about access to care that is related to, I won't say caused by, but is related to income security. You could also think about this in relation to sex, gender, race. And this is how we think about bringing in equity measurement into the survey, that we should measure all of our questions that are in the survey across these dimensions, sociodemographic and socioeconomic measures. So I will come back to the chat here. While I'm going to go to the poll, and then I'll come back and talk about the chat while people are answering this poll. First is around, do you plan to use an experience survey? So it's a little bit different than the prior question about like whether you're using it for ministry or own internal, but how you plan to implement this. So you plan to use an existing tool that you already have. Do you plan to develop your own tool, or maybe you already have developed your own tool? Do you have intentions of using the HSPN survey? We know that a number of OHTs are, but not all, and whether you're not. So if that's right, you can bring up the actual poll there. That will be great. And people can poll in and let us know. And meanwhile, I'm going to go and have a look at the chat while people answer that question. So I see here, as a patient, Sandra Holdsworth has written, I like PROMs or patient-reported outcome measures, but it has to be more about solving the problem than measuring, especially with mental health. I think that The reason we want to do all of this measurement is to identify those opportunities for improvement. And so I think that in mental health, so one of the things we might want to be doing is understanding for people with mental health, are we having more challenges in particular areas, either related to mental health or otherwise? Because we might have people with mental health may actually have a lot of difficulty accessing care or having particular outcomes that are particularly salient to their population. And we want to do more work in understanding different population groups as OHTs prioritize them too. Most of our work in this space has been people who receive lots of healthcare services. So I'll say many of them are, if you think about the home care population, older, more frail. And so we want to make sure we are more attentive to different population groups as OHTs become involved. There was a question about whether input of patients and family caregivers. So we involved about 14 patients and caregivers in reviewing the wording and the measures of the entire tool. And that was prior to OHTs really implementing. So it was in the first year when OHTs were just being approved, so fairly early days. And now that we're actually using it in the field and getting some of the results, we think it's really important for us to continue to go back to OHT populations, patients, families, and caregivers on an ongoing basis. And so so we did use, we've generated quite a bit of family and caregiver engagement from many aspects. Carrie mentioned that larger study, but we did dozens of others at home care and many others in other circumstances, as well as in the OHT. So that is essential. We're not done with that work. Leslie says, you didn't see this because only the host and panelists, please, when you're sending your chats, make sure you send them to everyone and building it into project evaluation plans and not implementing a broad client experience survey. I think that's very sensible in using surveys at the front lines. And we actually anticipated that most of the use of our survey would be in target populations. So early populations where OHTs were looking to make a difference, and that would be the primary early days. And HDGH, I'm not sure what that acronym is, using your own tools for real-time surveys on admission and discharge, sending the information leadership and physicians. Excellent. That's fantastic. Really happy to see that, pleased in the organizations. And then our tool, I think, is a little more based across the spectrum. So it's a little less sector specific, and it wouldn't be precise to a particular encounter with a particular provider for the most part. And with the questions and responses, I think that might be an application clear language. We've definitely vetted the questions and answers with the people that we've engaged with, not everybody. And that continues to be an ongoing basis. The survey is very long. I think that it is, when we talk to clients and caregivers, we asked what we should remove. And there were some items that we were able to remove, but at the end of the day, a number of the questions are, if you had many different encounters in the health system, you'll have a longer survey. I think the survey is only about 20 questions if you didn't see any specialists and you didn't go to the emergency department and you didn't use labs. So if you've used these services, then it tends to get a bit longer because we ask about those transitions.
Walter, sorry.
Yeah.
I was going to say, sorry to interrupt, there was some questions up top that may have gotten buried. There was one that asked about alignment with other surveys, specifically MOH's Healthcare Experience Survey and the Commonwealth Fund. And then also another question about the questions being translated into other languages.
So thanks for those extra questions. And I'm really, really pleased to hear those. So the first one is, yes, well, actually, we made a few sacrifices in our tool. We might have liked a few different questions in order to align with the Healthcare Experience Survey, the provincial survey. So where there were questions that had been implemented in the HCES already, we adopted those questions. So in a few cases, and this might be some of the awkward wording because we did not adjust that wording if it was already being deployed in the Healthcare Experience Survey so that we could have a comparator. Remember, our role is as an evaluator here. And previously, when we've used tools and gathered patient experience, we knew what the experience was in the programs, but we had no idea whether it was better or worse than anywhere else because we had no comparator. So this time, we've been very careful to make sure we had a comparator, and we made a few sacrifices, honestly, in some of the wording and some of the questions in order to be able to have the identical language to what is being used in the healthcare experience survey. And I've already forgotten the second question there, which related to Commonwealth Fund. So these are dimensions, but not the same. We look to align with the healthcare experience survey rather than the Commonwealth Fund. That was the main point. And I see there are, there's a same question as above from Rhonda. So which question is from Rhonda? Can go find that. Oh, Rhonda, were the questions vetted? Oh yeah, through clear language. So with that caveat of alignment with the healthcare experience survey, we did vet the language with everybody. And some of the questions, people might have liked them to be worded a little bit differently, and we stuck with the wording until we can get the wording changed in the healthcare experience survey, that we're gonna stick with our wording because we didn't want to double up on questions, and to be able to. Is there a plans to create a platform that could be used for administration and analysis provincially? So that will be a question we'll put to Zahra. At present, we have a platform that is available to all OHTs to use to collect the data, and then we will share it back to you. We do not have a platform yet for sharing the data back with you, but we do have a consistent way of collecting it, and we've made that available to all Ontario health teams. You can find it from our website. And the question around translation to other languages. So we have this available in French at present, and we are most pleased to work with people. And in fact, in some of our engagements, people suggested we should have it in other languages, and they volunteered that as we started to use it, they would help with the translations. So you tell us which languages we should translate, and we'd be happy to work with you to translate this tool into other languages. It really just, we want to make sure that there are sufficient people using the tool in those languages. We don't know which languages to use, so we made it available in French and English at present. Looking for ways to engage in Indigenous culture communities. So I will say we did not do Indigenous engagement at present with respect to this tool. We've worked with some of the OHTs that do have Indigenous populations on our evaluation and engaging in those ways, but I'll say we need to do more of that work if it's to be used in Indigenous populations. And is the tool validated? We have done much validation on prior tools. This tool, we're just in the field right now, and we need to collect data to do the validation, and that's what we're doing. So we'll be validating in as we collect the data. So we're now at a point over the summer where we can be doing some more validation work. Again, we've made this, we don't have psychometrics. People said the survey tool is long. It's actually too short to have proper scales within it. So we don't have like 3 and 4 items on each of those aspects and dimensions. We very only have 1 or 2 questions. So when it comes to psychometrics, it will not play out the way you might think a proper psychological instrument would. I'm going to stop there, I think, Kaylee, because we really, really want to get moving on.
Yeah, so we have yet to share the results from the poll. I think it's happening in there. So we can see a pretty even split with slightly more people plan to use existing patient surveys. And about 17% looking at the HSPN survey or 21% developing a plan to develop a new survey. And some others, which we've heard some examples already in the chat of what people are doing.
Yeah, okay. And I will come back to having a look at the chat as well. Okay, lovely. Thanks, everybody. And continue to share. I will continue to come back to that.
Yeah, as you're continuing to share, again, please let us know what your plans are for implementing routine surveys with the OHTs. So next we're going to hear from Sarah Grace Babnick and Sheila Koss from South Georgian Bay OHT. So over to you.
Thanks very much, Keely, and good afternoon, everyone. Thank you for the opportunity to present today, and thank you all for your attendance and participation. As mentioned, my name is Sarah Grace, and I'm the project manager for our South Georgian Bay Ontario Health Team, and I'm co-presenting here today with a member of our Patient, Family, and Caregiver Advisory Council, Sheila Koss. Next slide, please. So as you can see, the objectives of our presentation today are to provide an overview of engagement of patient, families, and caregivers in the South Georgian Bay Ontario Health Team, demonstrate how patient experience was measured across our OHT attributed population, and offer some thoughts for how you can use a similar process to contribute to your CQIP or OHT goals. And lastly, outline how moving forward, our South Georgian Bay OHT will work together to enhance the patient experience in South Georgian Bay under the leadership of our Patient, Family, and Caregiver Advisory Council, or PFAC. Next slide, please. So for those of you who may not be familiar with the South Georgian Bay Ontario Health Team, we provide services to those that access health and social care in the Collingwood, Clearview, and Wasaga Beach areas. We are one of 51 approved Ontario health teams across the province, working to provide a new way of organizing and delivering care that is more connected to patients in their local communities. Through the South Georgian Bay OHT, health and social care providers work as one coordinated team, no matter where they provide care, with the patient at its center. The South Georgian Bay OHT provides us with an opportunity to continue to leverage our strong and successful relationships and partnerships across the community to provide better integrated and connected health and social care services. It also provides the opportunity to form new relationships and connections and co-design care with our community members, including patients, families, caregivers, and those with lived experience. Since 2019, consultation across our community with organizations, governors, and patients, families, and caregivers has resulted in the development of our co-designed strategic framework for our OHT. This co-designed shared purpose, principles, and year one priorities began with a facilitated community symposium in December of 2019, which included health and social care organizations and patient and family advisors from across our community. We continued our generative process of engagement with all key stakeholders and submitted our formal application to become the South Georgian Bay Ontario Health Team to the Ministry of Health, which was approved in November of 2020. Following our approval, our partners held a second strategic planning session on January 11th, 2021, which of course included our partners, governors, and our patients, clients, families, and caregivers to really confirm our co-designed shared purpose, principles, and key priorities in our decision-making process that was established in 2019. The outcome of this discussion formed the following strategic plan and our year one implementation. And through the development of our OHT strategic plan to date, we have engaged families, caregivers, and patients related to our priority populations and projects identified by our OHT and our community. This element focuses on engaging patients, families, and caregivers in a population health management approach to improve the health outcomes of our priority population. Using a shared accountability and distributed leadership approach, we plan to collaborate with our partners, patients, families, and caregivers to advance our activities to support each of our year one priorities and our community. Next slide, please. So just quickly, based on this consultation to date that I outlined on the next slide, the following shared purpose and strategic framework has been developed, co-designed with our partners, governors, and of course, our patients, clients, families, and caregivers. This framework will be guided by our shared purpose and commitment to our community of co-designing an innovative and equitable system to anticipate, meet, and exceed the needs of all. It will inform our activities over the next year, the principles by how we work together as an OHT, and ultimately serve to be our framework for implementation, measurement, evaluation, and funding allocation. Next slide, please. Thank you. So as you can see in this diagram, to execute our strategic priorities, the appropriate action teams have been developed using a shared accountability and distributed leadership model with patient, family, or caregiver representation and anchor partner and project management support on each team to foster authentic collaboration. Each of these teams has a specific terms of reference and work plan, which has been developed by the committee, including our patient, family, and caregiver members, to support and engage with our broader community. And as you can see, to foster authentic collaboration, we've embedded representation from the PFAC in each of our teams and councils, with an example of this being on the chair of our PFAC sits as a voting member on our collaboration council. And through this role, we'll also have the opportunity to be the co-chair of the OHT if that's of interest to them. And I'll now pass it over to Sheila to explain more about our PFAC.
Thank you, Sarah Grace. The success of the OHT to date can be attributed to our strong relationship across the community, and our Patient, Family, and Caregiver Advisory Council, or PFAC, is no exception. Through our OHT PFAC, we work together to empower our community to advance change and work individually and collectively through the OHT to make a positive difference and co-design the best possible care for our region, engaging patients, families, and caregivers to support the South Georgian Bay Ontario Health Team was a top priority to truly co-design a new integrated health system and improve population health. Through the Ontario Health Team, we strive to enable meaningful patient, family, and caregiver engagement at all levels, from co-designing programs and services within our action teams to governance structures. Patient engagement in the Ontario Health Team is valuable in many ways and helps to bring a unique and valuable perspective to our work and helps to share their experience to inform program planning and development, which cannot be captured through data alone. Additionally, the perspective of the patient, family, and caregiver can identify gaps in the patient care journey and identify how patients will be affected by decisions, policies, and practices. The OHT, since the beginning of our development, we have supported patient, family, and caregiver engagement at all levels and stages of OHT implementation. This can be demonstrated through the approval of the South Georgian Bay OHT Patient Declaration of Values for Ontario and the Patient Engagement Plan, which outlines ways to support engagement at all levels of the OHT.
Thank you, Sheila. So to effectively support the goals of our OHT, we have meaningfully engaged our PFAC since the beginning of our development, beginning in 2019, as Sheila mentioned, using principles and processes established by the Change Foundation, as you can see here, to inform our early beginnings and development. We are now in the stage of accelerating and mobilizing change through collaboration across our health system and continued engagement by our PFAC and action teams to work together to advance our shared purpose and meet the goals of our OHT and TPA priority indicators in alignment with the Quadruple Aim. Next slide, please. So you've already had a chance to see this slide, and I'm sure many of you are already familiar with it. But to measure the effectiveness of our OHT in meeting our priorities and shared purpose in alignment with the Quadruple Aim, we have set out a series of indicators, and 3 of which are reported quarterly to support our Transfer Payment Agreement, or TPA, and included in our South Georgian Bay Collaborative Quality Improvement Plan. These indicators are the patient experience, the percentage of our residents and attributed population that are accessing virtual care supports, and how we have come together as a community to respond to COVID-19. To date, the patient experience across South Georgian Bay has been measured through individual organizations, patient experience, and surveys. So we haven't really had the chance to really have a complete baseline data set for our attributed population. With the development and the maturity of our OHT, we wanted to evaluate and analyze the patient experience at the attributed population level to better understand the familiarity of our community with our OHT and this new model of care, and their experience in our local health system to ultimately inform our future project planning, development, and implementation of the OHT. Next slide, please. So to solve this problem, our PFAC met to evaluate our options for surveying our attributed population. And through this process, which began in November, we extensively reviewed the HSPN Patient Experience Survey. Following review as outlined here, our PFAC recommended to our collaboration council to use the HSPN Patient Experience Survey and distribute it to our attributed population, which was approved. In South Georgian Bay, we're very fortunate that all of our primary care providers use the same PS Suite EMR system. As such, following the approval of the HSPN patient survey to be distributed, in December, we ran reports in our EMR system to identify all patients that had a primary care encounter in the last 2 years with and without an email. And just to specify, when we evaluated those with an email, we also ensured that they had provided consent to be contacted at that email address as well. One of the completed digital health and innovation projects through our OHT is to sustain an OHT Ocean license to primary care. And for those of you that aren't familiar with Ocean, it's a secure messaging platform that's used to get in touch with patients separate from just email. It was decided in collaboration with our primary care physicians that those patients who had email consent and an email address recorded in their chart would be sent a link to complete the survey in either French or English to their email via Ocean. To ensure an equitable approach to survey dissemination, 350 random patients were also selected without an email, and the survey was mailed to them with a prepaid return envelope. As a final step, once the link to complete the survey was closed, HSPN collected the survey results and is working closely with us to report back on the outcome of the survey. We're very grateful for the support of HSPN in the dissemination and the development of the patient experience survey and the support that they have provided us in analyzing the results. These results will be instrumental in providing us with the baseline data on this experience of our OHT attributed population. Next slide, please. So as you can see on this slide, through the distribution of the HSPN survey in South Georgian Bay by secure messaging and mail, we were able to yield a statistically significant response rate to inform the work of our OHT PFAC and OHT more broadly. This high survey completion rate provides us with valid data, which will be very important to inform future program development and help us to identify any gaps in areas of improvement, which the OHT can work to address. In addition to the survey response rate, we thought it was also notable to mention that when the survey was sent out electronically and by mail, we also saw a significant increase in the traffic on our OHT website, specifically our PFAC page, and received many phone calls and emails with excitement about the opportunity to complete the survey and gratitude for the opportunity for patients to provide their input to shape our local health system. Oh, sorry, Sheila, I think you're just muted. Thank you.
Sorry. This slide provides some early results of the South Georgian Bay OHT Patient Experience Survey developed by HSPN, and it illustrates patient confidence in their healthcare professional, providing them with the needed care, looking after them as they age, understanding their healthcare needs, and their confidence in knowing what they need to take care and manage their own health. Overall, these results are positive, but as usual, there is still work to do to increase patient experience and confidence. Through the OHT, all survey results, including these, will be evaluated using a population health segment approach by our South Georgian Bay OHT PFAC to identify any gaps and identify driving factors for these gaps, and opportunities of how we can work together through the OHT to address these by working on specific population health projects to ultimately increase the patient experience. With the support of the HSPN, we plan to survey our population annually to evaluate change in service delivery and the patient experience over time. Next slide, please. As mentioned, the results of the survey including the question about patient confidence, will be reviewed by our PFAC to evaluate opportunities for improvement. One example of how this survey is already informing the work of our PFAC is the patient advocacy tool showcased here to empower patients to ask their healthcare professionals the right questions. We hope that the development of tools like these for patients to access, for example, at their local library and online, will empower patients to have more confidence when engaging with their healthcare providers as a key member of the healthcare team. Our South Georgian Bay Ontario Health Team resources continue to be updated on our designated South Georgian Bay Ontario Health Team PFAC webpage, which is linked here. Next slide, please. So thank you all for your participation and engagement today, and we're happy to answer any questions you may have about the content that we have presented today.
Thanks, Sarah, Grace, and Sheila. Really great to hear about what's happening at South Georgian Bay, how this connects to your overall strategy of measurement, how patients are involved, and how you're going to use the data. So thank you so much. So are there any questions for South Georgian Bay? I did see one in the chat that was answered, and another one, were you able to connect the survey with patients who had no personal care providers or went through those who had personal care providers?
So our local Collingwood After Hours Clinic uses the same PS Suite EMR. So there would have been a few patients that have come through the After Hours Clinic. If they had an email documented and consent provided in their chart, then they would have been sent out the survey as well. But unfortunately, we're not able to have a full representation of those that access the system, just whatever, those that came through After Hours Clinic.
Great, thanks. And another question, what changes do you anticipate making as a result of this survey?
Well, I think that'll really depend on the results. As you can see through the slide that Sheila presented, we're looking at just as a first step, like how or what we can do as a PFAC and as an OHT to provide some simple like patient engagement and advocacy tools to help with that, with their experience in accessing services. And then based on, we don't have a full report of the results yet, but we're working very closely to get that information. And then once we have all of those results, we'll meet as a PFAC to really develop a work plan and a project plan in association with those results. And then that will be presented up to our collaboration council for approval. And we'll spend likely the next year really diving into those results to see what projects we can implement to increase the patient experience.
Great. There was a question about what percentage of your general population has no primary care provider, or do you have a sense of that?
We're fortunate in our region that we have one family health organization that represents the majority of our primary care providers, and then we have a few additional, and the community health center as well. And then we have a few additional primary care providers that are not formally a part of the FO or the CHC, but still use our same system. And based on the data that we've received from Ontario Health and from HSPN, that represents the majority of our population. But we're still, and there's a lot of work to do still to really make sure that we're continuing to reach that smaller percentage that are unattached, to make sure that they're still able to have a positive experience in accessing our local resources.
There was another question that went just to host and panelists. So again, just a reminder to everybody to send it to everyone. But does the ocean interface to your EMR or hospital data?
So the ocean interface connects into the EMR. So it's a tool that our primary care providers are using for online booking, sending electronic referrals, and to send messages to patients.
Great. Another question. Did you collect demographics data as part of the PREM? So that connects to the survey itself. And yes, there are demographic questions included. And another question, how are you reaching out to your community to let patients and caregivers know you have services available to them?
Sheila, did you want to take that question, or I can start? And
You could go ahead and start, and
Sure.
I'll add later if I need to.
Sheila and the PFAC as a whole have been really engaged to help us to drive our engagement strategy with our community. We do have a dedicated communication support through our Ontario Health team that manages our social media and website channels and sending out media releases and information. But then also looking at how to make it more of a multi-pronged approach to ensure that there's resources available in physician offices and libraries and some of those frequently touched community points, really just to continue to get the word out about the OHT. I think there's still a lot of the population is still kind of unsure about what the Ontario Health Team is and what that really means to them. So I think there's a lot of work to still be done around engagement, but that's where we've at least started to date. Sheila, is there anything else you wanted to add?
Our last short while, we've been really looking at the slide that I showed earlier about the patient involvement in their care. That'll be published, and we might even be able to get it in the newspaper, things like that. And we're also working on an advocacy poster or something like that, where patient caregivers, anyone can use that to help facilitate their journey through the healthcare system. Okay.
Great. And another comment on congratulating you on your efforts in collecting this data. There was a question, there was a bit of comment earlier about the length of the survey, and so it's nice to hear from you that you did get a bit of feedback in terms of the appreciation to have the opportunity to fill that out. So that's nice to hear. There's a question here about, and this is perhaps more for Walter, but for you as well, whether you got any feedback about the length of the questionnaire.
I'm happy to start, Walter, if that works for you. So that was one of the considerations that our PFAC did take into account when they were reviewing it. But to Walter's point earlier, when looking at it from the perspective of kind of a healthy patient or one that has low touch points with the system, it really was just a few minutes in length. And then it slowly expanded as the patient had more touch points or more different experiences accessing different parts of the system. But we thought that it was actually really valuable to be able to collect that information. And even if the surveys weren't fully completed, the information that does come back is always helpful. So we thought that it would be worthwhile to at least try and see what our response rate is, and then kind of use that as our benchmark moving forward. But it seemed from our results that there were many individuals the length wasn't really a factor for them, and they were happy to complete it. And it really provides us with more robust data that way as well.
Yeah, thanks. And so we are also looking very closely at what the durations were for people responding to the surveys, if there are sections that are longer or shorter. Note there are about 9 items that relate to sociodemographics and socioeconomics. I think it's really important for us to make sure that we are able to understand, according to age, sex, gender, race or ethnicity, as well as social determinants, how these things are impacting on people's experience. There are about 6 gate questions. So that means there are at least 6 or 7 questions that won't be answered if people didn't access that type of care. So it makes it easier as a yes/no question, as opposed to having to read the entire question only to say, I didn't use that service. So we're looking at all of this and looking to, where are the opportunities? Where do we gather information that we don't need? So that's, we want the briefest survey that has the best information. We don't want to give up on measuring the 6 dimensions of overall experience, we have such a robust background. We don't want to say, it doesn't matter if you can easily access care, we're just going to ask about something else. So we're working on it, continue to keep it open. The one other piece I wanted to mention, and why we invited Sheila and Sarah Grace to come today, is we actually had never really intentioned or thought that someone would go to their entire OHT population with this tool. We thought people would primarily use it within specific target interventions. Most OHTs would be starting out with very specific areas of improvement. And if you go onto our website and look through, we talk about whether, our threshold for sending data back to teams is 10 respondents. We actually thought that was meaningful at the time. And there are some OHTs that will be much more focused and are much more focused in how they've done it. We have another OHT that's doing it in a very frail population where they're actually have volunteers completing the surveys with most of their clients who are unable to actually do it themselves. So there are different methods and modes. This is just one of the examples that we brought today. And I just wanted to raise that. We don't expect people to go, to their entire OHT population, although you can. And then, we'll be bringing these data and comparing them to HCES results later this summer. That next update, we get the next update data in September, so around that time. So just to mention that we think it's very applicable within focus areas of work too. I think didn't see any new chats. Did I miss any, Kaylee?
No, I think we actually got to most of the questions. So thanks for everybody for submitting them. We didn't hear from many in terms of how you're involving patients and families in discussions. So we'd be happy to hear a couple comments or examples from OHTs about how you're doing that in your OHT.
Yeah. Like, has this been a discussion point around your patient family advisors being involved in more widespread capture? I want to really thank Sarah, Grace, and Sheila Koss for coming today and being part of this webinar and sharing their results and being brave and bold and stepping out and doing this. As some people don't want to ask because they're afraid of what the answers might be.
Well, thank you for the opportunity.
Great, thanks. And then with that, we can move to Zahra from Ontario Health.
Hi, Kaylee. Thank you for that. And thank you to Walter and the team for having Ontario Health at the webinar today. I thought maybe if we go to my first slide, I would start with an overview. One more slide, please. An overview of OH's strategic priorities. So these are the 5 priorities that are going to guide the work of Ontario Health. And the concept of person-centered care is really embedded throughout the 5 priorities. But specifically, when we think about patient-reported measurement and patient experience measurement, it really is priority number 2, which is transform care with the person at the center. Next slide. And I won't spend too much time here because every single presenter has used this slide, which is the Quad Aim. And the Quad Aim is really how we are evaluating our work at Ontario Health. We also don't explicitly include equity as a separate aim because we think equity should be embedded to each of these quadrants. Next slide. So in terms of OH's priorities with respect to patient-reported measurement, there's kind of 2 main areas of focus. First is to maintain our leading programs. And so as many of you know, Ontario Health is an amalgamation of 21 legacy agencies, so the LINs and agencies such as HQO and Cancer Care Ontario, et cetera. And so we actually do have a number of programs that have been around for a long time. We've been measuring patient-reported outcomes in cancer for over 10 years, are actually rolling out an orthopedic PROM as well in a number of hospitals. We have a PREM that's specific to cancer. And so we're going to continue to support and maintain these leading programs, but we really want to leverage the expertise that we've built in terms of those programs and think about how we do expansion into OHTs in particular. And we want to work with partners like HSPN and RISE and CIHI and the ministry to think about what is a provincial strategy for PREMs and PROMs, and what is this going to look like when we're trying to measure PREMs and PROMs within OHTs. To start, we are doing a proof of concept within cardiac care, so congestive heart failure, and are going to be looking at the collections of PROMs in about 6 OHTs. The 2 bullets at the bottom of the slide kind of are foundational to how we're going to do our work. And so, we're definitely going to be thinking about best practices and have expert advisory tables where we can talk about best practices and psychometric evaluation of our surveys, et cetera. And we're also going to continue to maintain a centralized electronic prom-prem collection platform. So we do have a platform right now where we collect our cancer proms as well as our hip and knee work, and that's live in about 70 hospitals. So we're going to continue to have governance of that platform, but we're also going to think about what do we need in the future and what's the best platform to be able to collect this type of data in the OHTs. I think the example we just heard about right now from South Georgian Bay was really amazing. I know the response rate was so high, and a lot of that was collected through primary care and using a different platform. So I think as a province, we'll have to think about what the right type of platform is as we move forward. Next slide, please. So I mentioned, our leading programs, but those aren't the only surveys that are touching patients. There's a lot of patient experience measurement that's happening in Ontario. Some of those surveys are created by OH and our legacy agencies, and some of them are outside of OH, and they're collected by other organizations. But when you think about this from a patient experience perspective, a single patient could be actually receiving all of these different surveys. And I think that OH has a role in rationalizing some of this. So thinking about, what is a measurement strategy for the province, and how do we coordinate in such a way that we're not having the same patient and fill out a number of different surveys, and really being targeted in terms of how we do this type of data collection. So this is something we want to refine over time. Next slide. Since the focus of today's webinar is really on the patient experience measurements, so the PREMs, I thought I'd spend a bit of time just telling you a little bit about our experience in cancer. So there is a PREM specific to cancer called Your Voice Matters. It's a couple of questions, and it's aligned to those concepts of person-centered care. It was launched in 2016, and it's live in 14 regional cancer centers as well as a number of other hospitals. We have about a 2% response rate across the sort of cancer population, but last year that was equivalent to 19,000 people filling out this PREM. And the PREM is been pretty well received by patients. You can fill it out kind of via your mobile phone because you get an email from your cancer center, or you can fill it out on a tablet when you're actually at the hospital. Next slide. Next slide, please. Yeah, one of the things we do with the data is we actually take the data because it's linked to health card and are able to analyze it by a number of different domains. So we're able to take the PREM data and cut it by disease type, so the specific type of cancer the patient has, age group, gender, the type of treatment they're receiving, whether or not they came from a rural or an urban part of the province, whether or not, what their income status was, what their immigration status was, and it allowed us to identify gaps in the patient experience. So being able to say, these types of patients are having a better or worse experience, and then allow the cancer centers to actually target their interventions to address some of these gaps. I think that's really the power of the data is, who is not having the best experience and how do we change that experience for those patients? And so we provide this type of data back to the cancer center so that it's actionable for them. Next slide. So, how does this relate to OHTs and where we want to go with OHTs? And this is a slide that was actually put together by my colleagues in strategy and policy. And this defines how we want patients to experience an OHT at maturity. So, we see the patient really at the center of the OHT, primary care around that in a concentric circle, and then the OHT around that. And we want the patient to be able to say, I can transition easily between my care team, and other members within the OHT. I have 24/7 access to navigation resources, etc. So if we want this to be the patient experience, how do we know if we're actually achieving this? And I think that's by asking them. We have to be able to administer a PREM or a survey with these types of questions and domains to be able to understand the patient experience. So, a number of years from now, 5 years from now, when OHTs are at full maturity, we know whether or not we're actually achieving this. And we have to be able to collect the data routinely to be able to track progress over time. Next slide. So that's one of the main reasons why it's important. I think one of two. The first reason is that I think we understand as people who work in healthcare that the patient perspective is increasingly relevant when we're thinking about overcoming some of the challenges faced by the healthcare system. So demographic, epidemiological, economic, etc. We need to embed the patient perspective into how we design care. And so being able to use the data to do that is kind of the first priority. But I think a second priority for the OHTs in particular is to be able to show that this healthcare transformation and how we're designing care through an OHT lens actually had a significant impact on the patient experience. And we won't know that until we actually collect this data. And so there's PREMs, but there's also PROMs, which gives you outcome data, and PRISMs, which tell you a little bit about social measures. And so I think that this data, if we're collecting it in a routine, sort of widespread way, will allow us to be able to make that value judgment on whether or not OHTs had the impact that we wanted them to have. Next slide. So, what is OH's position in terms of the types of measures we think would be relevant to collect? And this is early thinking and early discussions, and we haven't actually landed on exactly what this is going to look like, but I thought we would share this as early thinking. It probably makes sense to have all OHTs collect a couple of core measures so that we can be able to look across OHTs and have an understanding of the patient population across Ontario. So something like an EQ5D, which we talked a little about earlier, is like measures health-related quality of life of a population. Being able to collect that across all OHTs allows us to understand the health-related quality of life of people in Ontario. The PHQ2, which asks 2 questions related to depression, could be another. The HSPN PREM that we talked about today, there's a lot of really good questions on there that do actually touch on some of those concepts that we're hoping to understand in terms of OHT maturity. Appreciate, the conversation around length, et cetera. I think that's something that has to be sort of sorted out over time. But, in terms of routine collection, but I think there's a lot of really good concepts in the HSPN PREM that we'd want to maintain. And it's possible that we want to just be careful about how many people we ask to complete it, and what frequency we want them to complete it, that kind of thing. I think that OH could also offer a menu of condition-specific PREMs and PROMs as well. So we have things that are already built into our provincial platform. I mentioned the cancer ones and the Oxford hip and knee. We're now building the one for congestive heart failure. I think we can continue to build ones for other chronic disease conditions. OHTs have specified that they have different priorities that they'd like to focus on. And so if Ontario Health gave a menu of PREMs and PROMs that were specific to different patient populations, you could choose to implement them within your OHT, because that would give you some information about the focus that you're focusing on. In terms of the provider experience, at some point we want to be able to also do a survey to measure provider experience, and so we've talked a bit about that on the slide as well, but that's going to be sort of a second phase of work. Next slide. One of the guiding principles when we look at doing PROM and PREM measurement is being able to collect the data once from patients and use it 3 times. And I think this is really important. I think, again, coming back to not over-serving our patients, I think, we need to ask them questions that make sense at the micro level, so at the clinical level, and then be able to roll up that data to be able to summarize it at a meso level and provide it back to OHTs for quality improvement, planning, resource allocation, et cetera. Roll it up one more time to be able to use those questions at a policy level to think about, where's Ontario going with particular policies. So, I think this is really important. Whenever we pick a measure and we decide to do like widespread adoption of it, it has to be able to work at all 3 of these levels. And the clinical level is most relevant, I would say, for PROMs, so outcomes, so being able to ask a question about pain that's useful in the clinical encounter. But even from a PREM perspective, looking at experience, there are questions that make sense at a micro level and that can be used by individual clinicians or teams, et cetera, but then can also be rolled up and used at a meso and a macro level. Next slide. So where do we go from here? I talked about the fact that there is quite a few experience measures in the system. I think that OH, has this role to play in terms of establishing an inventory of what is already out there, working across different stakeholder groups and ensuring some coordination so that we can make sure these surveys are being experienced by patients in the way we want them to experience it. I also think that we're going to take a systems level approach to how we do expansion. So being able to work with the OHTs to collect some of these measures and provide support from a provincial perspective. We know that these measures are going to be really helpful for you when you're thinking about, what are the priorities that you want to focus on, how do you do your planning, et cetera. So one of the things I think that we should also do is provide reports and data back to you that summarizes it in a way that's actionable. So that's something that we'd like to do over time. I think that brings me to the end.
Great, thanks so much for the overview. It was really nice to hear Ontario Health's perspective, and I liked your commitment to using data in the different ways and including using it for OHTs to improve and do some quality improvement. So that really great and a great opportunity when we implement this to learn across OHTs and improve. There are a couple of questions in the chat that I just let you know about. So one is, seems like one huge priority population for patient experience is mental health. I think many of us know people who have found it virtually impossible to access care in a timely manner. Any comment on that population?
So I'm not sure if it's about an experience or an outcome perspective, but agreed. I think mental health is a major area of focus for Ontario Health. There is a Center for Excellence now been established within OH that's focusing specifically on mental health and the services and the gaps in the system. So, from a care perspective, there is some work happening in Ontario Health. From a patient experience and patient-reported outcome perspective, I think we realize that for mental health in particular, problems are important. That's the way a lot of assessment is done. So using a measure like a PHQ-9 to understand levels of depression in the population and then using it to target intervention and care is something that we would highly recommend as we think about models of care for depression. In terms of experience, I think there's a number of surveys that can be used to understand the experience of that particular patient population. So as I would say, the Center for Excellence Mental Health, and as they expand their programming, I would strongly encourage them to consider both the experience and the outcome measurement as they're rolling out service, because it gives us a chance again to understand that patient population, both from how what are their health outcomes, how are they experiencing the depression, but also what are their experiences in care and where are the areas where we can make some improvement. So definitely an area of focus, and I think that PROM and PREM measurement will be integral as we think about how we better serve those patients.
Great. There's a comment from Alan Katz about thanks for including the meso level process. Will OH be engaging OHTs to determine what kind of information they would like to see in the meso level reports?
Totally. And actually, if I get to do a plug on that, I'd love to do that. I think one of the things we're trying to do is we have a wealth of data that we've collected, on cancer and ortho, for example. And we've actually started a wireframe on using orthopedic data for OHTs to say, okay, we already have this data. We have data on how hip and knee replacement patients are doing in terms of their outcomes. We have data from the EQ5D. We have some data on the experience with their actual operation. And so we've tried to create a report for OHTs that's hopefully useful for you when you're thinking about those patient populations. So would love to shop it around to a couple OHTs and get some feedback on whether or not that report would be useful for you at the meso level. So definitely want to be able to work with OHTs to make sure that whatever report we produce is helpful to you, because that's the point of doing this, right? Is to collect the data and have it be useful for you. So if there are, OHTs that are willing to be able to, take a look at some of the reports that we're mocking up, we would be very happy to partner with you. And we're going to actually ask Walter for a favor to help us with that too. So
great, it'll be good to get the input. Another question, when it comes to innovation, is there a plan to utilize AI to roll out services for various communities, tailored based on collected data? And with that, great presentation, thank you.
So I think that would be amazing to be able to do something with advanced analytics or AI. I think that we need to get our house in order first, is probably where I'm at. I think that there is a lot of measurement out there, and I think that we could probably do a better job of sort of rationalizing it. I think that we need to think about the right tool and accessibility and languages and some of those things that were mentioned, previously. And so I think we're probably going to focus on the lower tech stuff first in terms of just making sure we have good access and the right measurement out there. And then I think, thinking about AI will probably be like a next phase, but there's a little bit of cleanup I sort of feel like we need to do first.
Great. And one more question to add around the mental health clients. Are there discussions around equity of access, including usability of different service populations?
So we don't have a consistent PREM, I believe, by OH on mental health. I think that's something we need to do in the future. And so that would be one of the components that would probably be included.
And I think there's just one more question. I'm not sure if we have time on it, but it is about provider OHs considering provider experiences. I know that's our topic for next month, but maybe you could touch on that briefly.
For sure. And, and Walter, happy to come back and talk about that, at another month. But I think we all realize that there's such high levels of burnout amongst clinicians across the system. And we know that provider experience, again, is a core component of the Quad Aim. And so we want to be able to understand the provider experience. But alongside that measurement, we really think it's important to give some strategies for clinician well-being and burnout. And so want to kind of develop both in parallel. We haven't endorsed a particular provider survey yet. but we do think that that's something that we need to do in the next little while. I think it would be nice if we used a consistent survey across OHTs or across healthcare providers. It allows us to do comparability of data from different jurisdictions and different, different areas, etc. So I think that's the direction we'd like to go in. But that is sort of like very early days, because we are focusing first on the sort of patient measurement and patient both outcomes and experience, and then I'm planning to do provider experience measurement after that.
Great.
You've given us a better segue than that, eh? Next month. Because, I mean, one of the things, and we started out about 2 years ago in the space of evaluation, was we noticed that many OHTs had singled out patient experience and provider experience. And when we looked over to see what the measure was for that, it was TBD. And so we found we had to fill the gap. So we had to, actually, I hadn't really thought about that prior, but then we figured we'd start here. We've done a fair bit of work. And so we have a provider experience survey that has also been used in a couple of the OHTs, is available, and we'll be back next month to talk about that. Thanks so much to Zahra, to Sarah, to Sheila today. And I want to come back. You've commented now on this idea of possibly, because you do have a lot of disease and condition-specific PROMs, on the condition-specific PREMs. And I wonder if Carrie or Sarah or Sheila have encountered that in their conversations. I know it's something that in our early work, when Carrie and I met with Betty Lou Christie, chair of the Patient Family Council for the Premier and the Minister of Health, I think, actually, sorry. And we had this discussion, and she comes from a background in mental health, and we had lots of discussion about future work with OHTs once they had identified target patient populations, including mental health, to have that specific work. But maybe Carrie and then Sarah.
Yeah, and so when we unpack the attributes of person-centered care, the populations that we talked to had all different kinds of health conditions, different social backgrounds. And what I think we're unpacking is that there are some core fundamentals that go across populations, but how they get operationalized when you actually respond to those attributes and seek to improve your services will be slightly different, or maybe more different for different populations. So a quick example, the go-to person, if it's someone with mental health and addictions, there's a lot of literature to suggest that a peer support worker or someone in the community with similar lived experience would probably serve as the better go-to person than maybe a primary care provider, unless there's a really strong relationship with that person and the primary care provider. So I think, again, core fundamentals, but operationalization might be different by population. So if you can segment them out to understand what those nuances are, but maybe provide a similar tool, it might be logistically easier without losing the essence of what the different populations need.
Do you want to add to that, Sarah Grace?
I think much of what I would have said has already been covered. As you all know, we took the kind of attributed baseline population approach for our survey. And then I think based on the results of that, we'll look at distributing out some more population specific surveys to evaluate really like effectiveness of our OHT programming and efforts or like to support our mental health population or our frail seniors population, because I think while they kind of baseline attributed population data is important, that the perspective of those more specific populations is equally as important for our program planning work. So yeah, just echo what's already been said.
Yeah, thanks so much. I think that's exactly on point. So I'm going to close off, or actually, Kaylee, you're going to close off, right? But I'm just going to bring up the slide for you to do that.
Sure. Just to say, there's a lot of comments in the chat thanking the presenters. So again, thanks for sharing your stories and your work. Just to highlight, there's the Organizing for Ontario Health Teams follow-up survey. So we did this previously in 2020 and 2021, and we're now running it again with all 3 cohorts. And it is the last week to complete the survey. So for those of you from OHTs who've received this, we'd really like to get your responses. And then next, as been mentioned, our May topic will be focused on measuring provider experience. And then after that, we'll continue our trip around the Quadruple Aim, focusing on health outcomes in June and costs in July. So we hope to see many of you back here to learn more about how we can measure the Quadruple Aim. And again, there'll be future topics in terms of population health management and segmentation. And when we get the results from that survey I just mentioned, the Organizing for Ontario Health Teams, we'll be happy to share those with you. So those will be some that are happening in the fall. Finally, here is our Central Ontario Health Team, or sorry, our evaluation team that was behind a lot of the work that we do. And that's it. So thanks very much for attending. Thanks again to our presenters. I look forward to seeing and hearing from you in the chat again. Great discussion, and that's it. Goodbye. Thanks, everyone.